My patient was a 59-year-old female whose chief complaint was acute chest pain, and her admitting diagnosis was unstable angina. Pre-existing conditions were type 2 diabetes and bipolar disorder. She had 3 previous strokes, but no residual weakness from those strokes. She had an x-ray, which showed some pulmonary edema, and an echo, which revealed preserved ejection fraction of 65% and no wall motion abnormalities and no valvular disease. But then she had a left heart catheterization, which showed severe coronary artery disease and occlusions and stenosis. So she had a CABG, and whenever she was my patient, she was 3 days post CABG, and so that's whenever my report on her is about. So I'm going to start with variations from the textbook, comparing and contrasting my patient with the textbook patient post CABG, 3 days. So the patient suggested that a post CABG patient might be hypovolemic because of blood loss and fluid loss during surgery, in which case it would be appropriate to increase fluids or administer blood. And then the HCP may manage the patient with volume replacement therapy, followed by vasopressor therapy to increase the blood pressure. And this is not the case with my patient. In contrast, she actually has fluid overload and pulmonary edema and generalized edema. Her breathing was very shallow and rapid. As a matter of fact, her lab values showed that she was in respiratory acidosis. Her pH was 7.48, her CO2 31, and her bicarb 24. So respiratory alkalosis from hyperventilation. Her breathing was so shallow and labored. She had dyspnea upon rest. The night before, she had been on a BiPAP up until that morning. So they had taken her off of BiPAP the previous shift. And so the shift that I had her was the first shift that she was breathing on her own after surgery. And she was definitely adjusting to that, having a bit of difficulty adjusting. But her capillary refill was fine, and her pulse was fine. Her pulses were strong, and she was still able to talk, and she had respiratory therapy, came in and gave her breathing treatments, and that helped her. And so she was getting better. She was on a diuretic to help get rid of a lot of that fluid, bumetanide, 2 milligrams PO every 12 hours, which is a diuretic for fluid overload to pull that fluid off. Nursing considerations for that: monitor I's and O's, which we were doing. She was on a fluid restriction, so we had to watch that carefully. She was getting daily weights to make sure that her weight was dropping, not rising. Blood pressure, all of her electrolytes and lab values have to be closely watched with that, as well as lung sounds and edema. She had non-pitting edema in her legs, but that was one way that my patient contrasted with the textbook. Another way, the textbook calls for using aseptic technique during dressing changes and of the incisions, the graft site and the CABG incision site. But my patient's incision sites were actually open to air, and at day 3 instead of being under dressings. And so there were no dressings or aseptic technique used. Even with her being hyperglycemic, with her being a diabetic, they still had her on an insulin drip. So all of her other medications, they had taken her there on day 3. They had moved her from IV medications and had transitioned her to PO or injections, but her glucose was still so out of control, going up in the 300s, sometimes even, that they still had her on an insulin drip. And so even with that being a risk for delayed healing, they still had her dressings open to air and they looked well. There were no signs of infection, no abnormal redness or swelling or drainage, and the edges were all well approximated. So her incisions looked well, but that was a contrast to what was mentioned in the textbook. And another way the textbook talked about a post-CABG patient, that the patient said, oh, well, I kind of already addressed this, that the patient would be on PO meds by day 3 of post-CABG. And like I said, my patient was, except for her insulin, which she needed the IV insulin drip still. So another thing to contrast are 3 reasons for variations in specific medications compared to the textbook. So my patient was on amiodarone. She was taking it 200 milligrams once daily. Amiodarone is recommended by the textbook also. So my patient did compared well with that, just like the textbook. It's for cardiac rhythm instability. Some post-CABG patients receive it according to the book because they are high risk for arrhythmics. However, I guess some patients might not if their rhythms remain stable. Another medication that my patient was on that I already discussed was the bumetanide for fluid retention and renal function. And the textbook also spoke of that loop diuretics are often used to manage post-operative fluid overload and pulmonary congestion. However, not every post-CABG patient needs that. The third medication discussed in the book, medications were Plavix and Levinox, which are for coagulation and to prevent VTEs and PEs. So some patients might only receive aspirin post-CABG according to the book to maintain graft patency, or maybe just aspirin and Plavix. But my patient was receiving both Plavix and Levinox. So that suggests that she is a high thrombosis risk, probably because of her age. Also, she has severe coronary artery disease. So I'm sure that also would be why. She's also not getting around, not ambulating as much, being older and not as active. Another way to compare and contrast with the textbook, reasons for variations in laboratory or imaging results compared with the textbook. So the diabetes mellitus and stress induced hyperglycemia. The textbook really didn't talk about how this might play a role in a CABG, but it could cause definitely higher than average glucose because of the stress of the surgery and the white blood cell values compared with non-diabetic CABG patients, and that rings true. My patient's white blood cell count was 19.7 on day 3. It was trending down from 21.3 a few days ago. So trending in the right direction, but still quite high. And another thing that she had was diuretic therapy and fluid shifts compared to the textbook. The diuretics are used to control fluid shifts after electrolyte levels and can cause dehydration and hyponatremia. So this might be the reason for my patient's elevated BUN level. Her BUN was at 31. It's quite high, though trending down, so going in the right direction from 35. And that's my 10 minutes. And so her BUN level, and she had other elevated electrolytes as well compared with post-CABG patients. And so that could be the reason why.